I'm going to try and gallop through this because we're running a bit late. And unlike everyone else who's had a very directed talk with a sort of a punchline, as it tells you on here, I'm going to talk to you about the known and the guesswork, the unknown, and it's bits and pieces. So there's going to be some stuff that's good, and there's other bits that's going to be purely opinion and stuff like that. Okay, so what do we know? And this is all in your slides and stuff, and so that'd be quite useful. So I'm not going to go through this, you can read it. So I'm really just going to talk to, very quickly, what do we know about BRCA mutations? What does it mean? And then more specifically, given that olaparib is now in the area, it's just got NOC from Health Canada for a particular indication it's been used. What's the mechanism of action? What are the side effects? Who should we use it in? Does it represent value for money? A few other issues like that. So just talking about BRCA in and of itself, there's lots of data out there. This is Australian data, so population-based, so as good as you can sort of get. It was 1,000 patients. And just interestingly enough, if you look at the germline mutation, so that's inherited, it's 14% of their population. Now we know that there's another 5% of the population who have got an acquired mutation. So actually BRCA positivity is probably present in 20% or so of patients. And as I'm going to talk about later on, there's also a BRCA-ness phenomenon or other genes that go wrong so that you don't repair your DNA correctly. So there may be 50% of people who have DNA repair problems who may benefit from some of the therapies that are coming up. Importantly in here, and it's relevant to the whole question of BRCA testing, is that 44% of their BRCA mutated women did not have a family history. So if you actually believe that you have to have a family history to initiate BRCA screening, you are wrong. Similarly, if you believe that you have to be young, you are wrong. So screen everyone with a high-grade cancer, or even more widespread than that, because the pathologists can't always agree on actually what the histologic diagnosis is. Prior breast cancer, you're very likely to be mutated. So just things. Outcomes, so they sort of drilled down to the serous, which is the traditional BRCA group. This is the high-grade serous, not the low-grade serous, which is a different animal. And as you can see, just quickly going through there, if you're mutated, your progression-free survival, either median or at 4 years, is better. And your overall survival, again, median or at 4 years, is better. So there are better outcomes for women who are BRCA mutated, and we all know that they are more likely to be platinum sensitive, will respond on more occasions to platinum drugs, and in fact to other drugs, as you'll see later on. And down the bottom, they were just looking at CA125, because actually in retrospective studies, no one does imaging for response assessment, so you use CA125. And as you can see, if you are mutated, you're more likely to respond again to chemotherapy, both in the platinum-resistant group and in the platinum-sensitive group. You see a bigger effect in the platinum-resistant than in the platinum-sensitive, but again, you're getting into this issue. The platinum-sensitive is selecting for a BRCA-ness, a DNA repair group of people. So that's probably the problem. So what do we know about PARP inhibitors? So we've got two things. We've got what we do know is their effectiveness, and we also know that they're incredibly tolerable, and we also know that they're given by mouth. So how do PARP inhibitors work, or what's the rationale? So basically, all of the time your DNA is going wrong. It's getting mutations. They're normally single-stranded. So to repair that mutation, you actually have to remove this product called PARP. You have to take it away from the break so that all the enzymes, etc., can come in and repair it. So the PARP inhibitor stops that from happening. So those single-stranded breaks are then taken through the cell cycle, and you double it. So you then get a double-stranded break. Now, double-stranded breaks are bad because one of two things will happen to your cell. It'll either repair itself or it will die. In a normal cell, there's really good DNA repair mechanisms. So it's homologous recombination, very effective, repairs the cell continues to live. But if you have, and it's saying here HRD, which is a DNA repair problem or a BRCA problem, what happens is you actually can't repair those double-stranded breaks, and that's lethal. The cell will then die and this is called synthetic lethality, but not being able to repair your double-stranded breaks accurately is really not good for your cancer cell. So this is not, and that's the other thing, this is not a cytostatic treatment, this is a cytocidal treatment. So we should be seeing response rates. So what PARP inhibitors are out there? There's one other company has one as well, but olaparib, niraparib, rucaparib, and velaparib, and I can actually say those fluently. Olaparib is the one that's around. Niraparib and rucaparib are not so far away. They're coming through their development process. Olaparib has now been approved by Health Canada in the same indication as used in the European Medicines Agency, so Western Europe and the United Kingdom, and that's platinum-sensitive disease, first relapse, you've responded, and you are BRCA mutated. In the United States, it's approved for a different indication, and there's a whole political story to why it's different, but they're then using it as a single agent in the third line. So as you can see, there's two different ways of using it. You can either use it sort of earlier on as a maintenance therapy, or you can use it later on as a single agent. And I can't tell you which of those strategies is better. There is no data, no head-to-head comparisons. I know what my own biases and my own beliefs are. So maintenance therapy is a sort of a hot topic, and it's a popular topic. And more and more people are thinking that maintenance treatment is a good idea. In the ovary cancer world, we've tried using chemotherapy. So actually you can do slightly better by giving someone Taxol for 12 months versus 3 months after your first-line therapy. We know that Avastin actually can increase the time to your cancer next coming back in a variety of situations, but including in the first-line sort of setting and in the second-line setting. So it's interesting. It may, and the point at the bottom I'm trying to make there is what's good for the system, i.e. funding, is not necessarily what is good for the patient. They're not necessarily, in fact, often not the same thing. So the idea of using a maintenance therapy and earlier on, so either after first-line treatment or second-line treatment, is, and you've responded, so your quality of life at that time is going to be the best because your cancer's sort of gone away, you're feeling well. So at that time, you can maintain your quality, a better quality of life. And also, the earlier in the ovarian cancer's lifetime you're treating it, the longer the progression-free survival in absolute terms. So instead of maybe getting 3 months of extra progression-free survival, if you can get 6, 7, or 8 months, so you can do things with your family, etc., that's a worthwhile strategy. So to be a good maintenance therapy, it has to be oral. PARP inhibitor ticks the box. Non-toxic, absolutely ticks the box. Marker selected, that's sort of a buzzword, but it means you're not treating people who won't benefit unnecessarily. It's a cost-saving thing. Also, you don't want to give people any of the side effects or the hassle, so that it ticks the box. Cheap, it really does not tick the box, and I'll come back to that later on. So that is going to be a major problem. What's completely unknown, however, is it better to do chemotherapy and then go straight away into your maintenance therapy? So straight away maintenance, I'll call it, or could you do just as well by doing chemotherapy, stop, and then when the cancer next comes back, give the PARP inhibitor at that time. So in a way, you could call that delayed maintenance. It's the same concept, you're just using it at slightly different time points. I do know that from patient groups and actually from my work with PCODA and stuff that the uncertainty of what's happening to you after treatment and not being on anything to keep the cancer at bay is a major issue for the patients, for the afflicted groups. So that's why I say what's good for the system and what's good for the patient, not necessarily the same thing. I like that slide so much, I just put it on twice. So what do we actually know, for a change? So study 19, study done with the olaparib, and this is where the Health Canada approval has come from, the European approval. Very simple study. Your cancer had come back. You were called platinum sensitive, so you were more than 6 months to coming back. We then gave you chemotherapy. You responded. And then you were either given, in this case, olaparib, a PARP inhibitor, or you were put on placebo, and then you were followed. Now, in this study, and importantly, there was no then subsequent access for the people on the placebo arm to PARP inhibitors. So this was a true study of the benefit of PARP. It doesn't tell me whether PARP later is any good. It just says having PARP, not having PARP. And what were the results? And this was the whole group. This is not BRCA directed, okay? So at this time, it wasn't sort of sure. So this was just everybody with a sort of high-grade serous carcinoma got into it. And this is the progression-free survival curve. And the rule of thumb is if you can stick your fingernails or one fingernail in between the curves, it's statistically significant and clinically relevant. And as you can see, you could have very large hands and get your fingernails up there. It's a 3-4 month improvement in progression-free survival. Now, this isn't all people, and as you heard earlier on, 20% of people are BRCA positive, another 30% may be BRCA-ness, and 50% aren't. So the effect's going to be diluted out by the people who don't tend to benefit. So then, after the study had finished, though prospectively they'd collected BRCA data, but afterwards they didn't sort of stratify that. They went back and looked at, if you were BRCA positive, did it matter? And it really, really did. So it's in the BRCA positive people, and that's there's a greenish curve up at the top there, with an 11-month median progression-free survival versus the placebo arm was 4.3. So that's a really big difference, much bigger than most chemotherapies and other things that I see coming through PCODA, 3-4 months progression-free survival differences. So that's big. Interestingly, though, in the people who were BRCA non-mutated, there still was a difference, and it was 7.4 versus 5.5 months. That's small, but again, there's a hint of some activity in that group, and that's BRCA-ness group. And I'll come back to that later on. There's some people not BRCA positive who might benefit from PARP inhibitors. That's not what the indication is. That's definitely off-label and terribly naughty of me to say. This is the update, an updated survival in the whole group, and basically you can't get your fingernail in it. So it wasn't really any better. Again, remember though, there's two groups of people in here, BRCA and non-BRCA mutated. You'll dilute out the benefit in the BRCA mutated by having the other 80% of people who maybe don't benefit. So when you actually look at the survival curve, this was a 15% maturity. Now you can see that you can start to get your fingernail in there. So there is an overall survival benefit. And at ASCO, there's further data being presented on this. So if it's being presented at ASCO, you can guess that it's not a negative result. So that there is an overall survival benefit result. But remember, there was, for the most of these people, there was no subsequent access to a PARP inhibitor. So it just says that having PARP is not better than having a PARP inhibitor. It doesn't tell me anything about having it later. That was not the study design. What really excites me the most is actually some of these patients go on it and you got much better responses or duration of response than you'd actually see with standard chemotherapy. So the pink boxes are with placebo and the orange boxes are with the PARP inhibitor. And this is the number at each individual time point who's still, or percentage, who's still on treatment with a PARP inhibitor. And as you can see, 15% were getting a PARP inhibitor for more than 5 years. And my normal experience with sort of chemotherapy in this situation, I might be heavy on chemotherapy for a year and a quarter on a particular chemotherapy. So this is just mind-bogglingly good. But as you can see, selected population. So there is some of them on placebo who are doing really well at 5 years. But there was quite a big difference. So there truly is something in the PARP inhibitors. One always likes to have confirmatory data to say that this just isn't a problem with numbers or one of those one-off random ones. So there was another study design that was done. It doesn't really matter what it was. This was actually PARP with chemotherapy followed by PARP or just chemo alone. It's toxic, so no one wants to go there in terms of using it, but it shows exactly the same thing. The fingernail test, it passes. So there are two studies that have shown that sort of a maintenance strategy is superior. Now, again, so I have that I'm a patient advocate and I'm also a system advocate, so I get very confused. It is not, the current cost of a PARP inhibitor in US terms is $13,000 a cycle. This is a study that's from the US using study 19 results, but using US numbers. And this really is more a budget impact type thing. So they had 22,000 patients. They then said that 5,000 approximately would be platinum sensitive, and I think that's a gross underestimate. In my practice, it'd be 60%. 20% are then BRCA mutated, so say 1,100 a year. The cost of giving them PARP inhibitor as a maintenance treatment versus never giving them a PARP inhibitor, so it's not quite a fair comparison, would be $169 million per year versus $5.5 million a year by not using PARP. Divide that by 10 for Canadian figures, and I think it's an underestimate. But there are going to be budget impact problems with this. We can't afford the current price of PARP inhibitors. Hopefully there will be creative financing strategies that will go on. But it does cost a lot of money. So if you don't use it as maintenance therapy, because that's one strategy, what about just using it as single agent? Is there any evidence that it actually works? Absolutely. So this is a study 42. Was in anybody who was BRCA mutated, so you could be pancreatic cancer, high-grade prostate, and a few other things. But the great majority of people in it were women with ovarian cancer. They'd been heavily pre-treated, and now they were platinum resistant, which means that you get lesser benefit from your platinum. So you're tending to move on to Calyx or something in the routine world. So what were the results? And the two analyses on here. Study 42 is that one I just mentioned, and then they added in all the other information that they can have, and the information comes out the same. The overall response rate's about 31%. Now that's pretty good in these people who've had 3 or more lines of chemotherapy. That's what I would expect, or maybe slightly better than you get with standard chemotherapy. What's really interesting, though, is the duration of response up there at sort of 8 months or so. Again, when I wrote a paper recently, which eventually is going to get published, we're using etoposide in a similar sort of situation, maybe 3-4 months of response duration. So there's something in here for a very non-toxic treatment. So another strategy to use it would be as a single agent when there's measurable disease, as opposed to using it as a maintenance treatment. And you can argue one way or the other for either strategy. Is any PARP inhibitor superior? And this is just looking at the BRCA mutated. The different data, as you can see, it's huge amounts of data I'm showing you, with 200 patients maybe, so it's really difficult to sort of tease anything out. Different patient populations. If you're sensitive, you're going to have higher response rates, so that's why R and S, which is resistant and sensitive, have lower response rates than when it says S. However, overall, they all look similar to me. I actually can't say that one PARP inhibitor is better than another. So the answer is, if it was available, you use whichever one you can get your hands on. There's absolutely no difference in the toxicity profile, so the much of a muchness, use whichever one you can get. And this was just very quickly to say there is a differential benefit of PARP inhibitors within subsets, and classically in the ovary world, we've broken people up into resistant and sensitive. So resistant is you get less than 6 months of benefit. Sensitive is you get more than 6 months of benefit. They've completely confused it by that was actually a first-line definition. Now it's being used second and third line, so it's all very confused, and I no longer understand. But essentially, if you're sensitive, so you get more benefit from your prior platinum therapy, you have a higher response rate than if you're resistant. And if you're refractory, which means your cancer grows on platinum, they still actually then had in the Fong study, which was the original one with olaparib, a 23% rate. So what I'm trying to say from this is you actually can't say that there's no group of patients who are BRCA positive who will not benefit from treatment with a PARP inhibitor dependent on their previous platinum benefit. It's less, but it's not zero, so we can't use that to say it's a stop-go rule. And in terms of side effects, as you see here, easy to manage: nausea, vomiting, fatigue, and anemia. They occur probably within the first week to 2 weeks. And then you stop for 2 or 3 days and it goes away and you can restart at the same dose. If it doesn't go away, you've got multiple sort of toxicities, come down a dose level. And then usually after 1 month, nearly everyone is asymptomatic. So this is a very, very easy, simple treatment, could be given anywhere, needs no expertise, specialist advice to do. The one kicker in all of this, and it's only a little kicker, but there is a thing called myelodysplastic syndrome. Myelodysplastic syndrome is a variant of, or a precursor of, or is in fact acute myeloid leukemia. If you develop it, you probably will die from it. It happens in our patient population anyway, and you see it. The more people have been treated, the more DNA damaging agents they've had, like radiation, platinum, the higher the rate. But the with the use of a PARP inhibitor, the rate is higher. And at the bottom, it just goes through all of the randomized data as opposed to all the guesswork type of stuff. It's a 2% rate in the studies that have been done versus in the comparator arm about a 1% rate. So it's up, somewhat in a hard-hearted way. If your ovarian cancer is coming back, I think worrying about dying from acute myeloid leukemia is not really an issue. You want good treatment now, and the consequences will be what they are later on. It does become an issue potentially, though, if it actually moves into the first-line maintenance, where actually maybe 20 to 30% of our patient population who were put into those studies are potentially being cured anyway by routine chemotherapy, then myelodysplastic syndrome may become an issue. Now, they've been less treated, so maybe it's not as much of an issue, but it's something we'll have to think about, certainly if it gets into, as people will want it to, in the first-line maintenance therapy. I had to look up I'm an internist in theory, but I had to look up myelodysplastic syndrome to see what it was all about and what it really means. It was so long ago. It's very non-specific, and basically you get blood count issues. Now, it's not chemotherapy where you get a blood count issue and then it goes away. This is a blood count issue that doesn't go away. And you're symptomatic in most people, and it's usually anemia. Quite often it's a thrombocytopenia, a petechiae type thing, and with or without infection. How do you diagnose it? The lab tells you. Your report will come back saying there's dysplastic cells, what's going on. You then do a bone marrow biopsy, and that's diagnostic. You see abnormal cell lineage. What do you do about it? Well, you call a hematologist. It's all very simple. For the most part, the treatment will be controlling symptoms, blood transfusions, platelet transfusions, use of Neupogen, antibiotics, yada, yada. In somebody who was younger, fitter, you maybe think was going to live longer or something, you could consider other sort of options. So that's the easy bit. That was the known. So what don't we know? So what are we guessing at, or what do we have hints of? Here's a list of things. Again, it's in your slides, and for rapidity, I'll go through. So I rather like calling things data torturing, because I try and make stories out of nothing. It's like making a silk purse out of a pig's ear, or a sow's ear, if you want it in North American. What do we know? Well, there was one study that was a randomized study. Stan Kay did it, and it was using liposomal doxorubicin or Calyx, which is a sort of a standard therapy. It was comparing it to 2 doses of olaparib, 200 twice a day, 400 twice a day. 400 twice a day is 16 pills. So it's difficult to take. So a lower dose would be good, easier to take, or maybe you could just change the formulation. And so studies are going on looking at 300 milligrams twice a day. What studies going on? And as you can see from this, we've got progression-free survival, you've got response rate, you've got stable disease for more than 2 months. And really, in all of these, 400 is better than 200, somewhat in terms of benefit rate, quality of life. The toxicity sort of is not really an issue. Progression-free survival. Sorry, how much on this? Sorry, wrong one here. So, the dosing I'll come back to in a minute. I was confusing myself. Comparing to the Calyx, the previous standard, and it is better in all ways if you look across there. The toxicity issue is slightly unfair because no one in their right mind uses Calyx at 50 per meter squared. It's a 40 per meter squared dose, and otherwise you would guaranteeably get some of the oral toxicity. An interesting thing comes up is in intraperitoneal chemotherapy, and so this is ignoring PARP inhibitors, but going back to the BRCA mutated. So again, this is retrospective analysis from a big American study who are randomized between an intraperitoneal program and an intravenous program for giving the chemotherapy. Now, they weren't doing BRCA genomic testing, so they weren't looking at the genes, but they were using an immunohistochemical test. And most of the people do not believe that immunohistochemical testing is a good way for looking for BRCA, so there's lots of issues with it. And as you can see, in this number of patients, 189 had aberrant expression, 209 had normal expression, so that's not the 80-20 that you'd otherwise expect, though the group who get into IP studies are probably selected for that. Now, if you go across ways instead of down ways, and if you look at the BRCA aberrant, so they don't have sort of normal staining, and if you look at IP versus IV, so on progression-free survival, 35 versus 20 months, and 84 months versus 58 for the overall survival. So those are huge differences. Whereas if you look at the BRCA normal, so not immunohistochemically abnormal, there's not really any difference. So that it may be that IP chemotherapy niche is in the BRCA mutated. Now, that does cause an issue, because when is BRCA testing being done? A year and a half later? So not when you're being seen up front. So really, you need to know BRCA status earlier. So our current paradigm for counseling, then testing, isn't working, so now we either need to do testing, then counseling, or the really clever way of doing it is reflex testing, so it's done on the pathologic specimen. Because if you remember, 15% of people have an inherited thing that you find in the blood, 5% of people have an abnormality that you only find in the tumor. So actually, reflex testing on the tumor is the way to go. This is very, very preliminary. You could quibble either way you like, but it's just interesting that the IP may be the way really to go in the BRCA aberrant, and maybe IP isn't so important in the non-BRCA aberrant. This is the thing about the dose, which I got ahead of myself before, but basically when you look at here, and there's different ways of looking at it and stuff, but it's just as you go across, all the numbers look about the same. CBR is clinical benefit rate, so that's CR, PR, and stable disease, because stable disease matters. Anything but progression is good, as I keep telling people, or response rate. And as you can see, the 400 BID is somewhat better than the 200 and the 100. So in the ideal world, you try and keep people at the dose that's 400 BID. In the practice, in a lot of the studies that we're doing now, we're having to come down one dose level or so. But that's probably by 50 milligrams, so you'd be on 350, something like that. So, and that I can't answer you. I believe they're very much similar at those type of thing. The other then question comes up, so if you've had a PARP inhibitor, is chemotherapy going to work afterwards? Because PARP inhibitors are so good, you've got DNA repair problems, and essentially are they just another platinum analog? Or is there something truly, truly different in here? Now, from those long-term responses that we saw, I think there's truly something different in here. What data do we have? So this is the study 19 population, so that was that platinum-sensitive randomized study that I showed you earlier on. When the PARP inhibitor or the placebo had failed, it was just followed what happened to the patients. Now, they're not the same patient population, because those people who've had a PARP inhibitor and then the cancers come back are not the same as people who've never had a PARP inhibitor. You're selecting out for a worse population. So I'd expect to see worse results in that PARP inhibitor-treated program. And yes, you did. So if you look at the CR/PR stable disease result rates, it was less good, but it was still 38%. So there still was chemotherapy activity afterwards. And then you can see that there's a difference whether it's platinum or other drugs. But the point I'm trying to make here is that, yes, chemotherapy will work after a PARP inhibitor. So it's not an end-of-the-road thing. It is another treatment option in the spectrum of things we have. I want to have it as an additive therapy to everything else that I already have. And there was some preliminary stuff that came out saying that taxanes weren't going to work very well when you failed PARP inhibitors. There was lab stuff saying that. Well, it's absolutely not true, because if you look here, these are response rates from elaborate trials, looking at it in slightly different ways. They're using CA125 or imaging. And as you can see, the response rates to platinum, taxane, or liposomal doxorubicin were up there. And this is response rates, not including stable disease. And stable disease is anything up to a sort of a 50% shrinkage. That's 35%. It's not chopped liver, it's still shrinkage. So chemotherapy will still work afterwards. Now, what we're seeing in some of the studies is we have women on PARP inhibitor. We're doing imaging every 2 months as part of the study. And then we find that 90% of their cancer is shrinking or staying shrunk, and 1 or 2 lumps are growing. That's truly, technically, progressive disease, so they should come off study. But it doesn't make sense, because most of the cancer is responding. And we know there's a thing called clonal evolution, so that different bits of your cancer have different gene profiles, so they behave differently. So intuitively then, and what we're doing is if there's just 1 or 2 lumps, we'll radiate it or cut it out and keep the PARP inhibitor going until the majority of the disease is progressing, because we don't want to take away a drug that's benefiting the most of you. Can I quote you any data to say that's the right thing to do? No. But it's what we do in BC, and it's what a lot of other people doing PARP inhibitor studies are doing. Complicated question. What sequence of drugs? And how might I do that? Because we've got 2 newish drugs out there that we can use. We can use VEGF inhibitors or we can use PARP inhibitors. Okay. Both have been used as a sort of a maintenance type strategy in a way. And there's no data. So again, I have to guess or try and give you my particular idea. Now, it only matters if you're BRCA mutated or if you've got, and if it proves that BRCA-ness or the HRD phenotype actually matters. If you're neither of those, then we're not going to give you PARP inhibitors. We would want to give you Avastin if it was funded. So it's not an issue. So it only applies to the BRCA or the BRCA in this population. There's various places you can see that you can use these drugs. Personally, I think you should use the PARP inhibitor earlier. Why is that? Well, Charlie Gourley from Scotland did a $1 million study that a lot of people don't like the results of. Don't ask me why. And he could identify genotypically an immunogenic profile and an angiogenic profile. Up front, 30% of people were immunogenic and 70% were angiogenic. Avastin led to worse outcomes in the immunogenic profile group. So again, Avastin later from that would make sense. Also, that immunogenic profile changed with time to become angiogenic. Again, makes sense to use Avastin later in a sequence if you're lucky enough to have both Avastin and PARP inhibitors available. The absolute benefit in progression-free survival that you see is bigger with a PARP inhibitor, and there's an overall survival benefit in the platinum-sensitive group. But remember, Avastin was used as crossover therapy or was subsequently available to a lot of these women. So it's not fair comparisons, because really we're talking Avastin early, Avastin late versus PARP never, nor now or never. I just want to say again, the most expensive way to use a drug is in first-line maintenance. So again, when it comes up, because it will come up, and I bet you the first-line studies will be positive, a more cost-effective way of using it, probably for the same degree of benefit, will be to use it in first platinum-sensitive relapse. And then go on to the VEGF inhibitor. And personally, I would use it in the platinum-resistant scenario, but that's a whole other talk. And at GOC, people were evenly split between wanting to use it in the upfront maintenance cohort versus platinum resistance. But now that the PARP inhibitors are here, that is a slightly different conversation. So my final topic, and I'll try and get through it as quickly as possible, this whole idea, is there a bigger population who can benefit from PARP? Because the indication is going to be for BRCA mutated, but there might be another 25-30% of women who could benefit from it. It's not going to be funded till we have data, so this is all for the future, but that future is actually fairly close. So you could actually define a BRCA-ness phenomenon by platinum sensitivity or not to your first-line treatment. That enriches for it, but as I showed you earlier on, even the resistant and the refractory can respond, so it's not good enough. Or can you define BRCA-ness? Who are these women? Can we pick them out? Is there something we can do to identify them? And this is just a very sort of simple schematic. Green at the bottom is the germline mutation, so that's inherited. That's the thing that passes down the genes. Now, you pick up one copy, so that's why not everybody who's got BRCA mutation develops the cancer, because you have to mutate the other gene. Then there's those people who've got an acquired mutation, so they've damaged 2 copies of the gene through whatever events make that happen. And then there's another group, the HRD positive. So we think that 50% of women potentially could benefit from this. Oops. Sorry. So there's 2 different ways of looking at this. So you could either look at the genes that cause DNA repair issues, and that's one way of doing it. That's an easier way of doing it in a way, but the trouble is we only know what we know. We don't know what we don't know. So those genes that we don't know about, so they won't be in the panel. So there may be other people that technique is not going to pick up. So the other way, which is on the left-hand side as you look at it, is you could actually, it's more like a phenotypic thing, you can actually look for the effect of DNA repair problems. So you're not actually trying to look at the genes themselves, but you can look at the DNA and you can see, can you see the consequences of DNA damage? Can you measure that? Is there some other test that you can do? So this is a panel of all the different genes that's being looked at in the just look at the genes type of a thing. So that's one way of doing it. The other way of doing it is you look at the consequences of all the genes that are going wrong. So you don't need to know what the genes are at all. You just need to know what the consequences of the genes are. Seems more logical in my head, but it will be proved, it's going to come out of all the studies that are going on because this is being added in. And Mark Carey might understand this stuff, but I don't. I have no idea how you do it or what it looks like or anything. But the 3 markers of genetic damage that you have from DNA repair problems are loss of heterozygosity, I can't even say it, loss of heterozygosity, still can't say it, telomeric allelic imbalance, they trip off the tongue, don't they, and large-scale state transitions. Anyway, those in the know can see these things and they can spot it and it's easy to measure. So is there any evidence to say that this might matter? Well, again, data torturing, numbers of 21, so this is even smaller than we see in germ cell tumours. Given olaparib or given placebo, these are all BRCA wild type, so they've not got an inherited mutation. So these are BRCA normal people. However, now they've got HHRM, so they've got some of these other genes that have gone wrong in this case. And then we looked and see, does the PARP inhibitor benefit that group? And that's the top line, the sort of the reddy browny one versus those getting placebo. And this is progression-free survival. As you can see, there is a benefit. So there's a hint that it is true that by identifying BRCA-ness in some way or other, there's probably hopefully another 20-30% of women who could stand to benefit from PARP inhibitors. The current way that the funding will go will be BRCA mutated, but that's just going to need advocacy, change to thought processes. The converse is if that's your BRCA wild type and you don't have any of these other genes that have gone wrong, so you're not a DNA repair problem person, the fingernail test is failed easily on this. The curves overlap. So in this group of people, if you don't have a DNA repair problem, then PARP inhibitors are not the drug for you to have.